All right. Hey, welcome back, everybody. We'll be starting in about 5 minutes, so maybe 5:35 sharp, we'll get going. Okay, we'll go and get started. Hey, everybody, welcome back. Thank you so much for joining us. We appreciate you so much, as always. We're really excited for this session. Megan's really cool. I think it's going to be a great one. The quiz details are, as usual, 5 questions. You just get 4 out of 5. You'll get full credit. We'll give you more info at the end, and we'll be hanging around if you have questions about that. And you will get your certificate within about a week. So as far as get started, hey, everybody, welcome back. Thank you. As far as questions going to Megan, so we'll be relaying your questions to her as we go. So preferably if you have questions that are dealing with what she's talking about at the time, you can ask them. And then all of your general questions, like if you have a question about GPA or getting into PA school or her personal life or anything like that, we can hang on to those towards the end during the Q&A. But if you have questions that are relevant to the case study, we'll ask those at the end of each case study. That way we can kind of segment it off and not like overwhelm her with too much at once. But yeah, guys, I think that is everything. We'll go ahead and get started now. Megan, if you're ready on that, it's all you.
All right, thanks, guys. So like I said, my name is Megan. I'm a PA in Colorado, I'm a neurosurgery PA. I graduated PA school in 2018, and I've been practicing for about a year, and we'll talk about how that math works out in a few minutes. So I am from Wisconsin. I was born and raised in a small town in Wisconsin called Fond du Lac. And I started my undergrad education at the University of Wisconsin-Fond du Lac, which is just a 2-year school. Going into school, I knew that there was some kind of professional education that was going to follow my undergraduate degree. So I wanted to start somewhere small where I could live at home, keep working. I actually worked 3 jobs during my first 2 years of college. And I just wanted, a smaller experience for my first 2 years. I transferred to the University of Wisconsin-Madison, which was a much different experience than the small little school in Fond du Lac. And I majored in medical microbiology and immunology. I was on a pre-med track. I thought that I wanted to go to medical school my whole life. That was kind of the goal. But the transition from Fond du Lac to Madison was actually pretty difficult for me. From going from a super small community college to really big university was pretty challenging, and my grades did suffer a little bit. I went from straight A's to a couple B's, a couple C's. And my advisor actually told me that I should hold off from applying to any graduate level education, because she didn't think my grades were going to allow me to accomplish my goals. So I'm just telling you this because it is possible to get to where I am today, even if you have a few hiccups along the way. So I waited until after I graduated to start applying, and I did apply to medical school. But during that time, I was also working as a CNA. So after I graduated college, had my bachelor's degree, I actually went back to community college, I guess, and got my CNA license. And I started working full-time as a CNA in a nursing home. And it was some of the most humbling work that I have ever done in my life and that I will ever do. It was very challenging, very hard work, very physical and emotionally taxing, but it was also really rewarding to work with those sweet old ladies every day. So while I was working there, I was friends with the nurses, and I told them what my goals were, that I was thinking about going to medical school, that I was applying. And one of the nurses told me that she thought I had a good personality to become a PA. And what she said really stuck with me, even though, to be honest, at that time, I didn't really know what a PA was. And don't be like me, don't apply to medical school without exploring all of your options. I'm just being real. I didn't know what a PA was. I didn't realize that they had such an incredible role in medicine. So while I was working as a CNA, I started researching PAs, learning more about what they do, kind of paying more attention to them when they would come into the nursing home to do their rounds. And I seriously started questioning why I wanted to be a doctor my whole life. And this is definitely something I should have done before applying, but it's okay. It all worked out the way it did for a reason. So I realized that I wanted to be responsible for patient care. I wanted to take care of people. I wanted to make a diagnosis and order labs and imaging and prescribe medications and come up with a plan. And I started to realize that I didn't have to be a doctor to do that. And it didn't matter to me if I had a title of MD or DO. But what did matter to me, and what I realized while I was working as a CNA, is that a collaborative approach to medicine was really important to me. I wanted to work as a team. I wanted to be part of a team. And I actually really liked having someone to take my problems to if I had them. So as a CNA, I could go to the nurse. And as a PA, if I have questions, I can go to my physician. So after applying to medical school, I changed my mind and decided I wanted to become a PA. And I just want to make it very clear, this was not a backup plan. Being a PA was never a backup plan. It was just a change of pace. It was, me realizing that that wasn't the right fit for me, and that being a PA was the right fit. So that's how I ended up where I'm at. While I was working as a CNA, so getting my patient care hours as well as just kind of figuring out my life goals, I was also a respite care provider for teens with special needs. So I'd just drive them around, we'd hang out, shoot hoops, go shopping, hang out at the library. And I'd also do any of the personal care that they required. And I was teaching Zumba a couple times a week. So that's what I was, patient care experience that I got in my gap year. And while I was an undergrad, I was also volunteering once a week at the Children's Hospital in the activities department. So the kids would come in and just kind of hang out. We'd color, play games, stuff like that. And I was also extremely involved in my church. It's where most of my volunteer experience did come from, was church volunteering, We'd plan weekly meals for students and I'd help make them. I organized retreats, just a lot of behind the scenes stuff at church. After I graduated and spent 1 year just kind of figuring things out in Wisconsin, my husband and I moved to, he was my boyfriend at the time, but we moved to California to be closer to his family. And this is where I got really serious about applying to PA school. So I applied to a bunch of schools in Southern California, as well as a few in the Midwest. And I ended up being offered an interview at Western University of Health Sciences in Southern California. It's in Pomona, California. I went to the interview, I was waitlisted, and a few months later I was accepted. And I graduated in 2018. We started in 2016. It's a 23-month program. We had 12 months of didactic year and then 11 months of rotations. We did 11 rotations. Each were a month long. I really enjoyed Western University. It's a health science specific private school. So they have a medical school, PA school, physical therapy, dental, podiatry. There's more. And they did a really collaborative approach to teaching medicine. So once a week, I think it was once a week, we would meet with students from the other schools and go over case studies together so that we would kind of learn what other providers' roles in patient care was. And I think that was actually really helpful for explaining to the doctors and, you know, the podiatrists and the physical therapists what a PA's role is in patient care. There were 100 students, approximately 100 students in my PA class, which is a pretty big class, but we really did feel like a family. We would share our notes on OneDrive. We'd get together to practice physical exams on each other. We'd have big study sessions before exams, and there are a lot of exams. And it really felt like a family, even though there were so many of us. So if you're wondering what it's like to go to a school with that many people, I actually found it to be really nice. Plus you could have your study group as well as a group of friends, and they could be separate, and it all worked out. After graduating in 2018, we actually left California. Southern California wasn't for us after living in the Midwest for our whole lives. We didn't want to go back to Wisconsin, so we moved to Colorado, where we still live. And I've been working for just a little over a year as a neurosurgery PA at a large private practice in Colorado Springs. It's a neurology, neurosurgery, and pain medicine practice. We have 5 neurologists, 2 neurosurgeons, a pain management physician, a neuropsychologist, 5 neurology PAs, 2 neurosurgery PAs. And I work one-on-one with one of the surgeons, and it's a great setup for us. Something I'm really passionate about is life outside of medicine and outside of PA school. It's one of the reasons why I started my Instagram in the first place. I was kind of told going into PA school that I wouldn't be able to maintain my fitness lifestyle. I wouldn't have time to go to the gym every day. And I was like, that can't be true. I don't believe that. I'm going to make sure that I get to do what I want to do in addition to, you know, doing my education. So I was able to continue going to the gym every day during PA school. I would wake up at like 5 in the morning and hit the gym before going to school, and then go home and study and go to bed early so that I could get up early the next day and do it again. It worked out for me, and it has been something that I've maintained as a PAC. You can find me in the gym every morning before work, and sometimes, you know, in between surgeries and stuff, and I'll see my surgeon down there too. We're always like the only 2 people in the gym. I also really love hiking and camping, and it was something that my husband and I continued to do while I was in PA school. It was super important for me to get out of the city because LA was not for me, and to maintain my relationship with him. We weren't married at the time, but you know, PA school was really stressful, and it's not just stressful on you as the PA student, it's stressful on your family and your loved ones as well. So we would still try to fit in a camping trip every other month or so. These are a few pictures from some trips we took while I was in school. but that was really important. And I think it's definitely doable. Whatever you're passionate about outside of medicine is something that you should maintain through school as much as you can. And then my faith has always been something that's really important to me too. And I definitely wouldn't be where I am today without it. And I'm very blessed to work with a surgeon who has very similar views to me in that regard. So how did I end up in neurosurgery? I went into PA school thinking that I wanted to do pediatrics, and my first day of my pediatric rotation changed that completely. Well, child exams were not my thing. I didn't love the interactions with the kids, the interactions with the parents. It just wasn't for me. I also really liked cardiology in PA school, and 3 of my 11 rotations were actually cardiology based. So I did an interventional cardiology, an electrophysiology, and cardiothoracic surgery rotations. And I loved all 3 of them. Cardio was my jam. I was actually super terrified of my general surgery rotation going into school. So a surgery rotation is required to graduate from PA school. And I was so scared. Like I was like, I don't want to do surgery. I don't want any part of that. I'm going to pass out. I don't want to see that. I was scared. But on my first rotation, which was interventional cardiology, I watched a cardiac cath. The patient ended up needing surgery, and I actually got to scrub in and assist on a beating heart coronary artery bypass graft, or a CABG. And it was honestly one of the best days of my life. I fell in love with surgery that day. And it was a turning point for me career-wise. After that rotation, after that day, really, I set up a cardiothoracic surgery rotation, and I absolutely loved it. I loved being in the OR, which like I said, I didn't think that would ever happen. And I love the camaraderie of being in the OR. I love the relationship between the surgeon and the PA, the super intense focus that you have on one thing for hours at a time, working with my hands, the extreme perfectionism. I fell in love with surgery. After the cardiothoracic surgery rotation, I also went on to complete my general surgery rotation, which, like I said, is required for graduation. And I really like that one too, but the cases just weren't as intriguing to me. They were a lot shorter, quicker. You could do easily 5 surgeries in a morning before clinic. And I preferred the longer cases that we did in cardiothoracics. So after I graduated, I knew that I wanted to do some sort of surgical subspecialty. And I ended up having 3 interviews with surgical subspecialties. I had an interview with ortho spine, cardiothoracics, and this neurosurgery position. And honestly, what did it for me was the connection that I had with the surgeon during the interview. I could tell that we were going to make a really great team, and we have. And in talking to him since then, he said that he sensed the same thing during the interview. I truly, absolutely love neurosurgery. I'm so obsessed with it. It's so cool what we can accomplish with a scalpel. We can take someone who's had chronic pain, and when they wake up from surgery in the recovery room, their pain sometimes is gone already. We can take someone who couldn't walk for more than 10 or 15 minutes because of lumbar stenosis, pain into the legs. And after surgery, a few months later, they can hike a mountain out here in Colorado. We can take someone who has a brain bleed and can't speak and literally give them their voice back. We can take someone with a terminal brain tumor who's losing their general function and help them to be able to take care of themselves in the last few months of their lives. So we make a huge difference with what we do in the OR. And as you can tell, I'm so in love with it. In addition to the difference that we make in these patients' lives, I also really just enjoy the surgeries themselves. Like I said, they're a little bit on the longer side, usually about 2 to 4 hours for instrumented cases, but we have operated for up to over 8 hours before. And I actually really enjoy that. Like I said, I love that intense focus on one thing for hours at a time. I love the precision that you need. I love the relationships that we make with our patients. Like I said, I've been here for a little bit over a year now. And so I've seen some patients through from initial consult, through their surgery, through their postoperative period, to now discharging them out a year after surgery. And it's just so incredible to see the difference that we've made in their lives. We do primarily spine surgery. I've only done a handful of cranial cases since I started. It's just not really what comes through our clinic. We pick up most of those cases while we're on call, and we're going to start taking more calls soon. So I will be probably seeing some more cranial cases coming up here soon. Surgery. So that's been interesting to see. If you've done the math, I've said a few times.
Hey, Megan, sorry to interject, but I think there's some technical difficulties. Your audio and video are cutting out right now.
Uh-oh. Sorry.
Hey guys, sorry to butt in like that, but I think something's going on with Megan's internet on that side, but we're going to call her really quick and try and get her back and see what's going on. Oh,
yay.
well, hey.
Are we back?
Yes, you're
Okay.
back.
All right. I don't really know what happened, but
Yeah, I think maybe the internet just cut out for just a second, but you're perfectly fine now. We see your screen.
Okay.
If you just want to share your PowerPoint one more
All
time.
right. This one. Are we back?
Let's see. I think it's still trying to share right now.
There it is.
Yep, we're back. Okay.
Says my internet is unstable. Hopefully we'll make it through. I am in the office, which I thought was the best place to be doing this.
Oh, you're good. If anything happens again, we'll just shoot you a text. And okay. But it looks like everything's working fine now.
Okay.
I think your camera might be off. I don't see your camera coming up, but that's fine. You don't have to worry about it. We can still see your presentation.
Okay.
All right, perfect.
Whenever.
Oh, there we go.
All right. Okay. So I think where we got cut off is I've said I've been practicing for about a year. I started in September of 2019, but I graduated in July of 2018. So that leaves about a year unaccounted for. I was actually unemployed for 13 months after graduation. It took that long for me to find a job. Like I said, I had 3 interviews with surgical subspecialties. Those were the only 3 interviews that I had, despite applying for hundreds of jobs. I'm not trying to be discouraging. I'm just trying to keep it real. Finding a job as a new grad, especially here in Colorado, was really hard. And I think part of it was probably moving from out of state and not having the connections here. But it was rough. It was the hardest year of my life, I think. I was pretty discouraged because I knew what I wanted to be doing, and I knew I wanted, I went to school for this. I put in all the hard work, and I spent a year looking for a job. But I'm here now. I love what I do. I truly believe that the wait was worth it. And I already mentioned that I'm a pretty faithful spiritual person. So I believe that was all part of God's plan for me to end up here with the surgeon that I work with, doing what I'm doing. It all worked out in the end. It's just the reality of it. It took me a year to find this job. So let's talk about what a day in my life is like. Surgery days and clinic days are pretty different. Sometimes we do surgery after a clinic day, so sometimes we can be in the OR and the clinic on the same day. I would say that my schedule is pretty evenly split 50-50 between clinic and the OR. When I am in clinic for a full day, I see about 10 to 13 patients a day, which is pretty low, but for new patients, I do see them for an hour. And my surgeon will actually go in and see them all after me. So we have to make their visits a little bit longer and our patient load a little bit later. It's not that he doesn't trust me, it's just how he chooses to run his clinic. Neurosurgeons can be pretty particular about how they do things. I'm sure you understand. So I'll go in for a new patient consult, see the patient, find out what they're here for, get their symptoms, get their past surgical history, examine them, and then go out and talk with my surgeon about what's going on. We come up with a plan, review the imaging together, and then go back in and see the patient again together. He really does value my opinion and always asks what my plan is, and we generally agree on that. And it has been a really great learning opportunity for me to go back into the room with him and see how he interacts and how he relays the plan to the patient. So like I said, I see new patient consults, I see follow-ups. So if we see someone and we need to order more imaging and then they come back to clinic to see us to follow up on the imaging, I'll see those patients. I see patients for their pre-op visits. We talk about surgery and what to expect after surgery. I see post-op visits, suture removals, ER follow-ups. Like I said, my supervising physician sees most of my patients. Something I didn't realize I'd be doing because I didn't really do it during school is a lot of phone calls. I spend a lot of time on the phone. I call patients every day, checking in after surgery or calling them back to answer questions. And I also have to talk to a lot of providers on the phone as well. So I'll call primary care docs to request clearance or call a pain management physician to talk about our pain management plan, or call hematology when someone's like pre-op patients' platelets come up really low. So I spend a lot of time doing that. It wasn't something I really realized I'd be doing, and talking on the phone always kind of made me nervous before PA school, but I guess I've gotten over that. I do take call with my surgeon. That means that anything that comes into the ER while we're on call, we have to take care of. We're usually on call for 72 hours straight. So ends up being like a Friday at 7 a.m. through, I think it's like Monday at 7 a.m. or that kind of stretch. Sometimes we'll do it for 96 hours, depending just on what they need from us. And we do that about once a month. So we'll cover any spine or cranial cases that come into the ER during that time. We are at a level 1 trauma center, so it can be pretty busy while we're on call. But just because we get called on a patient doesn't mean that we'll have to operate on them. So a lot of spinal fractures or small brain bleeds don't actually require surgery, and we'll just follow them while they're an inpatient and make sure that their care is coordinated. I work anywhere between about 40 to 60 hours a week, which is a pretty big range. And every week is a little bit different, and every week is pretty unpredictable, especially in the COVID era. So right now I'm averaging around 50 hours a week. And even on days when we just have like a half day of clinic and no surgery, I end up staying till like 5 or 6 at night, just because, like I said, phone calls, we have team meetings, all the behind the scenes tasks to get patients ready for surgery. And then I also try to get here about an hour before my clinic starts, just to do all my pre-charting so that the rest of the day is a little bit easier. All right, during surgery, what do I get to do? This is something I didn't really know going into PA school and even going out onto rotations. And like I said, I was pretty terrified of what I would get to do. So as a neurosurgery PA, we do primarily 3 different kinds of surgeries. We'll do lumbar spine, cervical spine, and cranial cases. Occasionally, we'll do something miscellaneous like a carpal tunnel release, vagal nerve stimulators for seizures, and intrathecal medication pumps, which is when we put a pump into the abdomen with a catheter that goes into the spinal canal, delivers medications directly there. But spine really makes up the bulk of the cases that we do. For lumbar cases, they can be further broken down into instrumented and non-instrumented cases. So instrumented cases would be things like T-lifts or transforaminal lumbar interbody fusions, or A-lifts, where we go through the abdomen. And then non-instrumented cases like laminectomies and discectomies. Cervical cases are almost always instrumented. We usually go through the front of the neck for those. And then cranial cases for things like craniotomies for tumor resections, burr holes for brain bleeds, and VP shunts. So first assisting as a PA starts from the moment I walk into the room. I'll check in with the staff, make sure we have everything that we need. I'll get the imaging pulled up on the big screen in there so that we have a roadmap to use during surgery. And then I'll help with positioning, which if you think about it for a lumbar case is actually extremely important. When we go through the back, we actually flip the patient onto their stomach after they've been intubated. And it usually takes about 4 people or more to get the patient flipped over. So I help with that. And then positioning, you know, we're in there for multiple hours. We have to make sure that everything is padded appropriately. We use a lot of x-rays during surgery to localize for the right level. So if we're operating at L4-5, we want to be absolutely 100% sure that we're operating at L4-5 and not L3-4 or not L5-S1. So we take multiple x-rays throughout the course of the surgery to make sure that we're at the right level, and I help with verifying the anatomy. During surgery, I help with suction, retraction, hemostasis by electrocautery and other means. I protect the nerves and the spinal canal. I can help. I've actually finally just got to start helping with closure. Like I said, neurosurgeons are a little particular, so it's taken a while to get to that point, but I'm starting to help with closing. I help with putting drains in, things like that. After surgery, I will check on the patient in the recovery room for a neuro exam, which is extremely important after working on someone's nerves and the spinal cord. We want to make sure that everything is working appropriately before we move on to the next surgery. And then I'll go up to the floor and do rounds on any inpatients that we have. And rounds consist of checking in with the nursing staff, make sure they don't need anything, checking in with the patient to make sure that their pain is adequately controlled, pulling out any surgical drains as necessary, and then just kind of being a cheerleader for the patients. Some of these bigger lumbar fusions can be pretty painful post-operatively, and I just like to go up there and give them lots of encouragement. And then I wanted to give you guys a few tips for if you are able to actually go shadow a surgical PA in person, some tips for the OR. The main thing is introduce yourself to everybody. It's always kind of strange to see someone in the OR and you don't know who they are. So make sure everyone knows who you are. Be nice to the circulator and the scrub nurse. You don't want to get on their bad side. Don't touch anything blue. And probably our biggest pet peeve, my surgeon's biggest pet peeve and my biggest pet peeve is when people don't read the room. So don't ask questions when things are tense. You know, if the surgeon is kind of joking around a little, it's probably okay. But if they're extremely focused and not talking, don't ask questions then. And try to stay out of the way, but also try to be helpful if you're in a shadowing position where you're able to be helpful. You should touch anything. So I'm doing this on my own. Everything I say doesn't come from who I work for or my student. And then I also wanted to note that I'm a UPA still. I've been doing this for about a year. I'm still learning before we move on to the case study. And it says my connection is unstable again, so hopefully we'll make it through this. Right. Our first case study is a 75-year-old male with a chief complaint of relatively acute decline in function. He, but primarily his wife, who gave most of the history, reported a 5-week decline in function. He was having problems with his memory, some gait disturbance, possibly some left-sided weakness, worsening incontinence, problems with decision-making, problems with his ADLs or activities of daily living. He was having problems dressing himself. And his wife said that this change was relatively acute. It didn't come on gradually. It was pretty sudden. So previously he had very high functioning and independent, usually a physician prior to retirement. a history of alcohol abuse, diverticulitis, hypertension, hyperlipidemia, and he had a pretty extensive spinal surgery history, but other than that, pretty normal surgical history. So, like I said, his wife provided most of the history, and in my examination of him, his affect wasn't quite right. So he just seemed a little childlike during the exam. It was kind of hard to interact with him. He required assistance from his wife to walk down the hallway. He leaned on her pretty heavily because he was having some left-sided weakness. And on my cranial nerve exam, he was having some diminished vision in the left visual field. So seeing out here was a little bit difficult for him. And then he had a left drift. So when we check drift, we have our patients put their arms out in front of them like this, close their eyes and their arms there, and he will go like this, which isn't normal. So he had previously seen a neurologist for these symptoms, and their workup included an MRI of the brain with and without contrast. And this is what it shows. So I know you guys aren't used to looking at MRIs of the brain, but I can tell you that this is a very large lesion on the right side with actually, let me go back, quite a bit of edema around it. It's very swollen. So this is a glioblastoma. His was a WHO grade 4. And glioblastoma is the most common, most malignant primary brain tumor. And primary brain tumor is one that arises from the brain tissue itself. Median survival for a WHO grade 4 is less than 1 year. And the age of the patient is the most significant indication of survival. So his advanced age didn't give him a great prognosis. We believed it was a glioblastoma based on the imaging, but we just wanted to check for metastasis to make sure it hadn't come from somewhere else in the body. So we checked a CT of the chest, abdomen, and pelvis, and that was negative. There were no obvious mets on the CT. We started Decadron for the swelling. It's a steroid, and Keppra, which is anti-seizure medication, because when you have a tumor that big, that's grown as fast as his did, and when there's that much swelling, there is high likelihood for seizures. Also, when we're planning on taking it out, there's a likelihood for seizures. So we started him on Keppra, and then we began surgical planning. He wanted to proceed with surgery. We tried to not talk out of it, but a tumor resection of that size is a pretty big deal. And like I said, it was a grade 4, so his prognosis wasn't awesome, but he was pretty persistent that he wanted it out. And he just wanted to gain some of his function back because, like I said, he couldn't even button up his shirt by himself. So in this case, surgery is aimed at cytoreduction, or just reducing the size of the mass to relieve the mass effect. So like I said, that was pushing on quite a few things in his brain, causing those symptoms. And then we also wanted to obtain tissue for a diagnosis to guide the treatment plan. So with all of that edema, there's also a pretty high likelihood that the tumor spread. So after surgery, he was going to require chemo and radiation therapy as well. We performed a right stereotactic guided craniotomy for resection of an intraaxial tumor. That was the name of the surgery that we did. So we actually use neuronavigation during surgery. We have a CT and an MRI prior to surgery. We do some fancy maneuvers with some fancy instruments during surgery, and then we can actually see the tumor on the imaging on a screen during surgery with instruments that we can touch on the patient and correlate where it's at anatomically with what we see on the screen. Hope that makes sense. I'm actually going to talk about neuronavigation again in a little bit more detail. So we used anatomic landmarks, gross evaluation of the tissue, so you can, when you've been doing it for as long as my surgeon has been doing it, see the difference between normal brain tissue and pathologic brain tissue during surgery to tell if you've made it to the edge of the tumor or not. And then, like I said, we also use neuronavigation. The pathology came back as a high-grade glioma, again, a primary brain tumor. We were able to achieve a gross total excision. After surgery, he was left with a partial left superior quadranopsia. So he had a little bit of trouble seeing up here. We told him that we could potentially take out his whole left side of his vision, just based on where the tumor was at, but we actually were left with just a little spot that he couldn't see. He completed a few weeks of inpatient rehab, and then, like I said, he went on to have radiation therapy as well as chemotherapy, and is doing well in regards to his brain tumor. Or last time I checked in on him, he was having some issues with his diverticulitis. So hopefully he's still doing okay. I haven't seen him in a while. So that's the first case. Any questions about that?
So we've got a lot of really good questions. Majority of them have been more general. So we'll hang on to them until the end.
Okay.
But yeah, guys, if you have questions about the case studies, this would be the best time to ask them so that we can refer back to her immediately. And then all the general stuff, we'll be sure to ask and just ask it at the end. I think we did actually just get one.
If you guys come up with questions about the case, we can talk about this.
Okay, perfect. There is one question though, if you don't mind. It's Elijah. He is asking, how would you go about a case like this where the patient wanted surgery while the doctor advised against it? How much weight does the patient's wishes really have, and how do you decide what's the best route?
Sorry, Megan, I don't know if you answered it or not. You kind of froze right after we asked the question, or I don't know if you heard us.
Are we good? I think I might be having some internet problems again. I'm sorry, guys.
Oh, no, you're fine. Can you hear us?
We're like cutting in and out pretty bad.
Can you hear us?
Oh, kind of heard you.
Okay, I can see you now. Are you able to hear us? Uh-oh.
No, I didn't catch a question. I'm gonna try to yeah, kind of. I'm gonna try to change my internet connection maybe. I don't know if that will help.
Okay, sure.
Okay, let's try this internet and see if this works better.
Sure.
Nope, not from beginning. Oh, sorry guys.
No, you're good.
Okay, I'm on a different internet. Hopefully now we won't have so many problems. Can you see my screen?
Yeah, we
Yes,
see it perfectly.
you can see your screen.
Okay, and you can see me and hear me.
Yes.
Okay, were there any questions about the first case?
Yes, yes.
Okay.
So
Okay.
we'll start with this one from Elijah. He's asking, how would you go about a case like this where the patient wanted surgery while the doctor advised against it? How much weight does the patient's wishes really have? And how do you decide what's the best route?
Yeah, I wouldn't say that my surgeon and I were particularly against this case or against this patient having surgery. We just knew that, you know, if his median survival is less than a year, probably even with surgery, and the potential for inpatient rehab could have been about a month. I believe he spent about 2 weeks in inpatient rehab. That really gives him about 11 months after a surgery like this to really, you know, see the benefits. And even after inpatient rehab, there's quite a bit of recovery time. So we didn't advise against it. We just spent a lot of time counseling him and his wife. His wife wasn't super thrilled about the idea of doing this surgery either. So we spent a lot of time counseling him about what to expect, about the fact that he would need radiation and he would need chemotherapy, and that recovery from the surgery was going to be very difficult. But he was adamant that it was what he wanted to do. He didn't want to spend the remainder of his life completely reliant on his wife for his ADLs, his activities of daily living. He wanted to be able to dress himself. And, it was a surgery that we were capable of doing. And, there was a good chance for him to get 11 good months out of it or so. So we went ahead and did it. And actually, when I saw him back for his 2-week post-op, he was doing amazing. He told me that he had dressed himself that morning. Talking to him was like talking to a different person. He didn't rely on his wife to walk around anymore. And he and his wife were both extremely grateful that we had proceeded with surgery. So, patients do have weight in the decision-making process. We won't do a surgery if we don't believe that the patient will get better. So we do encounter this a lot with patients with back pain, which we'll kind of talk about coming up. Back pain isn't something that we see get better with a lumbar fusion. It's the radicular pain, the shooting sciatic pain into the legs that gets better with surgery. And a lot of patients are insistent that they want surgery for their back pain, and we don't believe that they will get better, so we won't do it. So, there is that balance between our opinion and the opinion of the patient.
Thank you so much. And that's such incredible news. It's so nice to hear how well he's doing right after. And so the next question, so someone asked if you could repeat the treatment. They said they weren't able to hear.
The name of the surgery? It was a right stereotactic guided craniotomy for resection of an intraaxial tumor.
Wow. Yeah, I don't blame them for not hearing that one. That's quite a mouthful.
Yeah. So it was right-sided. Stereotactic guided is the neuronavigation. Craniotomy is opening up the skull. Resecting an intraaxial tumor is taking out a brain tumor coming from the brain.
Awesome. Okay. Thanks for breaking it up like that for us. Oh, by the way, I think your connection's a little bit better now. It seems to be working pretty well.
Okay, awesome. I'm really sorry that we went that long with me using a poor connection. I hope you guys were able to catch most of what I was talking about.
No, don't worry about it at all. We appreciate you being here. So that's minor inconvenience. Thank you so much. There were a couple more questions about the case study, if that's okay with you.
Yep.
Okay, perfect. So let's see. Camille is asking, did the patient show a decrease in proprioception due to the lesion on the right side?
Not that I found on my exam. That is a pretty specific question, though.
Oh yeah, definitely. They like to put you on the spot. We have really smart viewers here, so be ready for that. No.
I've actually never found a decreased proprioception on exam, now that I'm thinking about it, but it does happen, and it is part of my exam.
Man, that's incredible. You deal with just such pertinent things. And I think the last question that we have is, there was a small discussion that broke out in the chat about the Decadron and the purpose of that drug in this patient.
Yeah, so there's quite a bit of swelling and edema on his MRI, and it also helps with, I believe, the seizure prophylaxis prior to surgery. I can show this picture again. I don't know. You can see on the picture on the right side, the tumor is kind of well circumscribed, but then there's a lot of lighter gray color that goes up. That's all swelling. That's all edema, and the Decadron can help with that.
Wow, that's amazing. Okay, but I think that's all of our questions for this case study. The rest will hang on until the end.
Okay.
All right,
Oops, that was a sneak peek. All right. The next case is one that I actually learned quite a bit on, something I thought I knew quite a bit about. So like I said, I've only been doing this for about a year. I'm still learning, and this is a case where I definitely learned something. So this was a 32-year-old male with a pretty unimpressive past medical history and past surgical history. His chief complaint is, he said, when I do this, when I look up, my third and fourth fingers bilaterally go numb, and they kind of curl up like this. That was his complaint. no pain. Well, a little bit of right shoulder and scapular pain. But other than that, no radicular pain, no shooting pains into the arms. And his exam was normal. There was no weakness and no hyperreflexia. And we'll talk in a second about why that's important. So I was kind of just like, well, just don't do that then. But normally I would have looked at his image prior to going into his room to see him. But I think in this case, he like brought his disc with him and it was taking a long time to load and I was getting tired of waiting. So I just went and saw him. But if I would have looked at his imaging prior to going in, I would have seen this, which is a pretty significant cervical disc herniation. So it's kind of hard to show you the MRIs just on a presentation like this because we scroll through and you kind of get a whole picture, like a 3D picture of what's going on. But I'm just giving you a one slice picture. So on the top left, we're looking at the cervical spine, the neck from the side, and you can see the vertebrae lined up. They're all labeled for us there. And then you see the gray, dark gray spinal cord behind it. And on both sides, you see white spinal fluid. But your eye immediately gets drawn down to the C6-7 level where it's pinched off there. The spinal cord is pinched. There's no spinal fluid surrounding that spinal cord. And on the right-sided picture there, that's an axial cut. So we're looking at the patient laying on his back from his feet up. So I wish I could like use my mouse to, point out, what we're looking at. But trust me, the spinal cord is compressed.
Sorry, Megan, to butt in, but you actually can use your mouse. So whatever you point out on your screen, they can see.
I have a touch screen. I don't.
Oh, okay. Well, in that case, sorry. I didn't realize.
If you can see on the right screen, it says C6. If you go a little bit below that, there's kind of a triangular shape. That's actually the spinal cord. It's very compressed. If you look down, I put in a normal axial cut below it. The spinal cord is the gray circle in the middle, and it has white spinal fluid surrounding it. So that's through a level that isn't compressed. And if you compare that to the one above, I think you can probably see the difference there. So his symptoms were being caused by pretty serious spinal cord compression, which is a big deal. So, like I said, this is a cervical disc herniation with spinal cord compression. And the upper extremity symptoms that he was experiencing, the numbness and tingling and the curling of his fingers, are called Lhermitte's sign. And that's what I learned about in this case. Lhermitte's sign, I'd never heard of that, and I hadn't actually seen it before in practice. So what that is a sign of early myelopathy. And we'll talk about cervical myelopathy. Myelopathy is the result of spinal cord compression. So like you saw in that picture, it's kind of like there's a really tight rubber band around the spinal cord, and signals then from the brain down past that lesion or past that compression don't get through as well. So patients might come in and say, my arms don't work like they used to. I used to have really good handwriting, and now it takes a lot of concentration for me to even just write my name. Or they might say, I have problems with balance. I have a hard time walking in a straight line. I bump into walls in my house that I know are there. On exam, you might find them to be extremely hyperreflexive. So when you tap on their reflexes, they jump. They might kick their leg out really hard. That's a sign of spinal cord compression. You might also find a Hoffman, which is when you check a reflex in their hand, their thumb will jump. Clonus, which is when you jerk their ankle and it bobs like this. They might have a spastic gait, so they might kind of walk like almost like a zombie a little bit. And then that's cervical myelopathy. And like I said, the Lhermitte's sign is a sign of early myelopathy. Myelopathic patients, we don't really consider them to be elective surgeries. We do them relatively urgently, especially in a case like this. He's a young guy, it came on kind of acutely. In older patients where it's been going on for a long time, we can give it a little bit more time between seeing them in clinic and getting them into surgery. But at this point, with COVID going on and our elective cases being canceled, myelopathic patients aren't actually considered elective. We need to get them done because of that pressure on the spinal cord. So I did mention that he had some right shoulder and scapular pain. That's actually a radicular pain. Usually you'll hear about it going all the way down the arm and into the hand. In his case, it was just in the shoulder. And then I talked about how this was a case that gets done relatively urgently without a lot of conservative management prior to surgery. But I did want to talk about conservative management here. So preoperatively, before a surgery for symptoms, say if he just had pain into the arm and we were going to go to surgery to fix that, we would like to see that he had tried to get better with conservative options prior to surgery, and insurance companies like that too. So things they could try are anti-inflammatory medications, physical therapy, steroid injections, chiropractic care. Actually, as neurosurgeons, you would think we don't like chiropractors. We do. We use our chiropractors a lot. Dry needling, stretching, yoga, things like that. So he didn't have to go through all those steps because he had spinal cord compression, but those are things that we do have to ask about and document for all of our patients. So we did, I was talking about why hyperreflexia. In his case, he wasn't hyperreflexic. It was an early myelopathy, wasn't long enough for that hyperreflexia to set in. Just wanted to mention that. So we ended up doing a C6 to 7 ACDA, or anterior cervical disc arthroplasty, or disc replacement. We didn't have to fuse him. We did a disc replacement instead. And this isn't him. This is actually not even 6'7", I don't think. But this is a disc replacement. It's a ball and trough joint. I think I brought one in here. I don't know if you guys can see this, but it is a trough and a ball that work together to preserve cervical motion. So he's still able to move his spine, his cervical spine, like normal. This is something that we're able to do in our younger patients who just have the right anatomy for it. Not everybody does, but he did, and we were thankful that we could do a disc replacement for him instead of a fusion. And he actually came in for his 2-week post-op today, and he was doing awesome. So that's the second case. Any questions about cervical myelopathy or disc replacements?
Yeah, we do have some questions on that. And thanks for showing us that. That's really cool.
Yeah, I don't know if you guys could see that, but.
Oh, yeah.
We can see it. Looks just like the picture.
So Heather's asking, can you explain how a hernia in the back differs from degenerative disc disease?
So a herniated disc is part of degenerative disc disease. So degenerative disc disease encompasses a ton of different stuff. It's basically arthritis of the spine. So it can be bone spurs or osteophytes. It can be ligament overgrowth, like degenerative discs, so compressed discs in the back, or a herniated disc like the one here. I would say that a herniated disc is part of degenerative disc disease, if that makes sense.
Yeah, and then let's see, somebody else is asking, Emily's asking, so would this be considered elective surgery, and what kind of neurosurgeries are considered elective?
This one wasn't so much elective because of the spinal cord compression. Things that we're considering elective right now are things like a herniated disc. So it's causing nerve compression, but it's not compressing the spinal cord. So unfortunately, the patient is in pain and is unable to have surgery right now, but as long as they aren't weak or losing function, it's going to be considered elective right now. We do have some patients in our clinic who have things like lumbar disc herniations who are weak. It can cause weakness, and those are not elective. Those need to get done because they're weak. So if they're myelopathic or they're weak, we're getting them done because they are not elective.
I see. Thank you. Let's see. So Alejandra is asking, are cervical disc arthroplasty an all size fits all, considering it's an emergent case?
No. I mean, I'm not sure I totally understand the question, but one size fits all in that, we could have done a fusion for him instead. Like I said, it's based on the anatomy that we find on x-rays. We do flexion and extension x-rays prior to surgery to see if they'll be a good candidate for an arthroplasty versus a fusion. So you can see flexion and extension x-rays actually on the screen right now. The patient will look all the way forward and all the way back. And then based on what my surgeon sees when he looks at those x-rays, he'll make the decision if he thinks he'll be able to fit an arthroplasty into that space or not, or if there's so much arthritis that the patient will just have to have a fusion instead. And if the levels above and below look healthy enough to be able to support an arthroplasty. And then as far as sizing goes, I'm not sure if this was the specific question, but there are multiple sizes of these things. They come in different heights, different widths, different lengths. And we use Medtronic products. We have a Medtronic rep in our OR every single instrumented case. So they help us with the sizing. And then we also use trials during surgery for sizing. So we have different sizes of everything that we can try before putting in the actual arthroplasty or graft for fusion.
Awesome. Thank you for that. We have a couple more questions on this case, if that's okay.
Yep.
Okay, thank you. So the next one's a good one. They're asking, how long do disc replacements last on average? And is this something that would have to be redone in a matter of years?
That is a really good question. That was something I asked when I started as well. They're actually pretty new products on the market. They have been around for probably about 10 years or so. And so that's the data that we have right now. However, we haven't found anything to suggest so far that they will require replacement or revising in the future. I don't believe that my surgeon has seen any patients that he's had to revise that specific level because he did an arthroplasty instead of a fusion. And actually, in the long run, it prevents you from having problems further down the line. So if you think about fusing a joint in the neck, the joints above and below, and this is true for the lumbar spine as well, the joints above and below take on the extra load that specific joint that you fused used to do. So the joints above and below can take on added arthritic changes over the years because they're doing extra work. So the thought is that by putting in an arthroplasty instead of fusing, that you're going to help to preserve the levels above and below for the future. So I don't have a solid answer for you on how long one of these will specifically last, but the idea right now is that they shouldn't have to be revised down the line.
Okay, awesome. Thank you. So Heather is asking, can degenerative disc disease be onset from a physical injury?
Yeah, so we actually I just discharged a patient from clinic who was 3 months out from her lumbar discectomy. She was using a chainsaw on the bed of a pickup truck and fell off the pickup truck while the chainsaw was running. And she herniated a disc in her back. I would consider that to be an example of degenerative disc. I guess it depends on how you look at it. Is it degenerative because of aging, or is it degenerative because of an injury, or is it both? It all kind of compounds on each other. But yeah, it's definitely going to be something that she deals with down the line as well, probably because of this injury, but she's also a little bit older too. So she already had arthritic changes in her back. Hopefully that.
Wow, that's a hardcore older lady.
I know. I was like, let's not use chainsaws in the back of pickup trucks anymore. That's not what the bed of a pickup truck is for.
So one more question on this topic. Anne is asking, is a cervical disc arthroplasty better than a fusion, or is it an easier surgery?
Ooh, I would say neither, actually. Definitely not easier. The process to get down to the the level that we're working on, the process of cleaning that disc out of there, all the osteophytes, all the arthritic changes that are the reason that we went into surgery in the first place, and freeing up the nerves on both sides is the same regardless of if we do a fusion or if we do an arthroplasty. So that part of the surgery is exactly the same. It's just what kind of instrumentation we put in that's different. So just one small part of the surgery is different. So I wouldn't say that one is easier than the other. As far as if it's better or not, that depends on the patient, and we would never, offer an arthroplasty if it wasn't warranted. And if we have the option to do an arthroplasty instead of a fusion in a younger patient, we only do them under 60 years old, we will, because like I said, it can prevent arthritic changes at the level above and below in the future. It's all patient dependent. We actually have a 49-year-old patient coming up with 2-level disease, and his anatomy just isn't suitable for an arthroplasty. So we'll have to fuse his 2 levels. And for him, that's the right surgery for him. It doesn't mean it's any better or worse. His arm is going to feel better whether we do the arthroplasty or the fusion. It's just how it's going to work out for him. I feel like I have one more thing to say about that, but it escaped me. So hopefully that answered your question.
Yeah, no, that was a great answer. But I think that's all the questions for this case study. Thank you for answering those.
Perfect. All right, we have one more case to talk about. This patient is a 69-year-old male, again, without significant past medical or surgical history, just kind of the normal surgical history of a few ortho surgeries. His chief complaint, and I say chief complaint loosely because he had kind of a lot of complaints going on, was 2 to 3 years of low back pain with radiation into the bilateral buttocks that was worse with upright activity and better with rest and flexion, so bending forward. He could only walk about a block or less because of this pain in the buttocks. And he could only stand for about 5 minutes or so at a time. He felt better when he sat down. And then he also said that his legs just weren't quite working right. He was having some balance issues, and he said that it took more concentration for him to walk. He really had to think about it. His legs just weren't quite listening to what his brain had to tell him. He said he felt like his feet were slapping the ground when he walked. He also had a left lower extremity pain that went through the posterior lateral thigh and buttocks, so kind of the side and back of the thigh, and then into the lateral lower leg. And he had paresthesias, or numbness and tingly feeling, in both of his feet. He didn't have any upper extremity dysfunction, just the lower extremities weren't quite working right. His exam was pretty benign. He didn't really have much for reflexes. That's what DTR means. He did have some decreased sensation to light touch in the lateral left lower leg, where he was having that pain that I was talking about. And then when he walked, it just looked like he was in quite a bit of pain. He had an antalgic gait, but otherwise nothing concerning on exam. So he came to us with an MRI of his lumbar spine, which you can see here. And if you remember back to the cervical MRI that we looked at, when you looked at the vertebrae on the sagittal view, or the ones on the left, you could see the spinal canal really clearly behind the vertebrae. It was smooth. All of the edges of the vertebrae were nicely lined up. The discs were all where they were supposed to be. They weren't really bulging, except for that one that was bulging that was causing the problem. On this one, you can see it looks pretty messy. There's arthritic changes and degenerative disc disease at every level. And I took a few cuts of the axial, or the looking from the bottom up on the right side, and there's quite a bit of spinal canal compression or central canal compression at this level on the right, but then at the left you can see all of the nerves are kind of freely floating. So I again wanted to just show you a healthier level versus a pretty degenerative level. So the image on the top right shows central canal compression, and that results in, when it's in the lumbar spine, we talked about what happens when it's in the cervical spine. When it's in the lumbar spine, it results in what we call neurogenic claudication. So and it's because the quada equina, or all the free-floating nerves, are compressed and not the spinal cord itself. When the spinal cord is compressed, you get dysfunction. When the bundle of nerves are compressed, you get neurogenic claudication. And those were the symptoms of the buttock and posterior leg pain that worsens with upright activity, is worse when he stands, worse when he walks, and improves when he sits. This is the cause of that, when the quada equina is starting to get compressed. In this patient, the conus medullaris, or the spinal cord, the tip of the spinal cord, terminates at T12 to L1. And that's where the nerve roots begin. So as you can see, he's got quite a bit of arthritic changes throughout his entire lumbar spine. We were pretty concerned when he told us that his lower extremities weren't working like they were supposed to, because like I talked about before, that's concerning for myelopathy. That's what happens when the spinal cord is compressed. And we already talked about in the lumbar spine, there isn't spinal cord anymore. There's just the nerves. So there must have been compression somewhere else causing those symptoms, because he didn't have any upper extremity symptoms. We didn't expect it to be coming from the cervical spine, but he was having lower extremity symptoms. So we got an MRI of the thoracic spine, and I have that here. You can see at T11, T12, which is labeled on the right side, there's again spinal cord compression. And actually this time there is cord signal change. That's when the spinal cord is a little bit different color on the MRI. We call it a bruise on the spinal cord, and that's due to injury or compression. That's pretty concerning stuff. So he has thoracic myelopathy. He also has lumbar stenosis resulting in neurogenic claudication, and he has a lumbar radiculopathy, or that sciatic type pain and paresthesias into the lower extremity. So he's got a lot going on. Thoracic myelopathy, I want to talk about a little bit more. It's pretty similar to cervical myelopathy that we already talked about. Anywhere distal to the level that's compressed is going to be affected, which is why he had the lower extremity dysfunction, but no upper extremity dysfunction. He wasn't hyperreflexive, like we've kind of talked about can happen with myelopathy, but also in older patients, they have diminished reflexes anyway, so it wasn't totally surprising that he didn't have hyperreflexes. And he was symptomatic, obviously. His legs weren't working like he wanted them to, and he had concerning stenosis on MRI. So we knew we had to address the T11, 12 levels. And thoracic surgery is not something we often do. I want to throw that out there. I haven't been in the thoracic spine very often. He also has lumbar stenosis, like we talked about, resulting in neurogenic claudication. Is thought to be due to ischemia of the lumbosacral nerve roots during the compression. And when you see an older individual at the grocery store leaning forward on their cart, they probably have lumbar stenosis and couldn't get through the grocery store without leaning on their cart. So it's actually something I ask my patients when I'm concerned for neurogenic claudication. I ask them, what would you say to me if I told you you had to go to the grocery store and do a full week's worth of grocery shopping, but I didn't give you a grocery cart? And they would tell me that they can't do it. And then I would be concerned for neurogenic claudication. He also has that lumbar radiculopathy, the shooting nerve pain into the lower extremity. His is in an L5 distribution, so buttock, posterior lateral thigh, and into the lateral lower leg. This is a dermatome that I have, a dermatome diagram that I have up on the screen here. I still refer to this quite often. I keep one at my charting station, and it shows you the distribution for each nerve. So if someone comes in and says, I have pain that wraps around from my buttock over the top of my thigh and into the middle of my knee, you might be suspicious for an L3 radiculopathy, which comes from the L2-3 level. So this is how we kind of start to break down where a patient's symptoms are coming from with their MRI and their symptoms and their MRI. So like we talked about, the definitive management for spinal cord compression is to get the compression off of the spinal cord. So surgery for that T11, 12 level. And then he also had slippage of one of the vertebrae on the other at that level, which is called a spondylolisthesis. When you have a spondylolisthesis, we have to fuse. Not always, but I'm not going to get into all the technical details of that. He also had compression of the spinal canal from L1 to L5. He had, like we talked about, pretty extensive disease. And he had a spondylolisthesis at L4-5, so that's slippage again of one vertebrae on the other. And when he would bend forward or bend back, that slippage would increase and decrease, which is why we ended up fusing that level. So his surgery was a pretty extensive one. It was the one that I was talking about that took over 8 hours. And we did we didn't have to fuse those levels because there was no slippage of the vertebrae on each other.
Oh, she just.
Hey guys, sorry about that. We're gonna try and get Megan back, but it should just take 1 second. Maybe just some technical difficulties. Oh, hello again.
I'm so sorry, you guys.
That's okay. No worries at all.
You know, it's weird. It was like perfect, and then all of a sudden it just dropped out of
Out of
nowhere.
nowhere. It wasn't even going in and out like before. It was just gone.
I hope that you guys are all sticking with me, and I apologize for all of these technical difficulties.
Oh,
But we're
no,
almost
you're good.
through, so if that means anything. All right, I wanted to talk about his surgery a little bit more because, like I said, it was pretty extensive. We did some crazy things. We really wanted to make sure that we didn't have to fuse him from T11 all the way down to L5. That is a big fusion, and we wanted to try to avoid that for him. So we did what I said, and if you didn't catch it, I'll say it again. We did a T11, 12 laminectomy infusion plus an L4-5 TLIF, and then laminectomies from L1 to L4. So the picture here on the left is a lumbar laminectomy. We take off the spinous process and the lamina and just free up those nerves. We don't actually go into the joint during this surgery. During a laminectomy, we don't interfere with the joint, so we don't have to fuse them. We normally will do this when there is pressure on the spinal canal, but not on the nerves. So at the levels that he wasn't having any radicular pain, we were able to do this. However, at the level where he was having that radicular pain into the leg at L4-5, we did have to fuse him. We do have to go into the joint to do that. And you can see in the middle picture why we have to go into the joint is to get that graft in that goes where the disc space is to hold things open and to help with the bony fusion to prevent movement or slippage in the future. My role during this part of surgery is to hold the spinal canal or the thecal sac out of the way so that it doesn't get injured during surgery. And you can kind of see that happening here in the middle picture. The picture on the right is the neuronavigation that we use during surgery. So we will take essentially an intraoperative CT scan, x-rays in a 360 that provides us with this imaging that we can use as a roadmap during surgery. We have instruments that correlate with that imaging so that we can see in real time where we're placing our screws to make sure that we're putting them in the best position possible for the patient. So there's a camera reflected down onto the surgical field during this part of surgery. It picks up the instruments and then relays everything to the screen that we can watch on. It's pretty cool stuff. Let me take another, we spin again after we're done to make sure that the screws all look really good and that they're in the positions that we want. So this is what his surgery ended up looking like. There's 2 levels of fusion. You can see the L4-5 fusion, the interbody graft in between those 2 vertebrae to hold things open, like I said, provide lordosis, make sure that those nerves aren't getting squished anymore so that his leg feels better. Then we did laminectomies all the way up to the other fusion, except for T12 L1, we didn't have to do that level. And that's to free up the thecal sac where those nerve roots live so that he can walk without feeling that fatigue in his buttocks that he was having, that neurogenic claudication. And then the picture on the right is the T11-12 fusion that we did. There's no interbody graft there because the spinal cord still lives up there. We can't retract that enough to sneak a graft by it. So we didn't end up putting one there. That's okay. The way that it's fused, and also it's the thoracic spine, it doesn't have much motion anyways. So it should be fine without an interbody graft in there. That's what his surgery ended up looking like. It was a long one, but we've seen him back a few times now. I think he's like over 6 weeks out from surgery, and he's doing awesome. He's able to walk around without those symptoms that he was having before. Those were gone pretty much immediately after surgery. His leg's feeling better. He still has a little bit of numbness, but that's normal. It can take quite a long time for numbness to improve after surgery, but he's not having those shooting pains anymore. And most importantly to him, he's walking better. His feet aren't slapping the ground anymore. He feels like his legs are listening to him again, and he doesn't get that fatigue and have to sit down or lean forward like he used to. So he's doing great. And that's the last case study I have.
Awesome. We did get a few questions about that case study. So someone is asking, is open reduction and internal fixation an option for any cervical issue?
Well, that's more of an ortho thing for like fractures. I wouldn't say that's something that we do.
That makes sense. Yeah, I can't imagine you going into somebody's neck and then like moving it back into place manually.
I mean, so here's the thing. We had a lumbar burst fracture while we were on call a few months ago. And a burst fracture, like it sounds, is when the vertebral body just kind of bursts apart. There's a lot of fragments in there. So when they are, pushing into the thecal sac, that's pretty bad. We don't want that to have any compression back there. So we went in and fused up a level and down a level. You can't actually put any screws into the level that's burst because there's nothing of integrity there. And after that surgery, things were reduced in the sense that some of those burst fragments kind of came back together because we took pressure off. So in that way, we reduce things. And then also a spondylolisthesis, or that slippage of one vertebrae on another, we are able to reduce those during surgery just with the rods and screws and manipulation of those. So I guess in a sense, we do reductions. It's just in a different way than like fixing a broken arm.
Man, that's crazy, but perfect. That makes sense. So someone else is asking, what's the difference between myelopathy and stenosis?
Stenosis leads to myelopathy. So stenosis is the structural reason for myelopathy. That stenosis causes compression. Stenosis and compression are kind of interchangeable. And that leads to the myelopathy. I guess one way that my surgeon talks about it, I'm not sure if you'll be able to see this. Yes. So if you just put your fingers around something like this and you don't compress it, it's okay, right? You're not going to have any symptoms. And you can get tighter and not have any symptoms. So this, I guess, technically would be stenosis if normally the space is supposed to be this big, but it goes down to this big because of arthritic changes and ligamentous overgrowth. This would be stenosis, but not compression. However, when you get compression and it's tight in there, that's when it can lead to something like myelopathy or neurogenic claudication.
Okay,
Wow.
perfect. Yeah, thank you for the visual. That made it a lot better to understand. One person is asking, what are the therapy precautions for that patient?
I'm assuming that's like the bending, lifting, twisting precautions that we have on patients. He will wear he'll actually wear a thoracic lumbar brace for 8 weeks after surgery. If we just did the lumbar spine, he would wear a lumbar corset brace after surgery for 8 weeks. We tell patients no bending, lifting, twisting immediately after surgery. We want them to have a neutral spine. That's the main thing. So in the future, he'll be able to go golfing again. We just need him to fuse first. We need that bony healing to occur. It's kind of like when you break a bone, it takes a few months for that to happen. It's essentially the same thing that's happening here. We're trying to encourage bony growth where we do that fusion. So while that's happening, we don't want him doing excessive twisting, lifting heavy weights, and we do have them come in. Well, we have them all see physical therapy after surgery. They help with those kinds of precautions and how to navigate daily life without doing things like that. And then they usually have questions for me when they come into their post-op visits about what's totally recommended and what's not. So we'll go over things like that during those visits. Like I said, no bending. It's really no excessive like curvature of the spine. That's what we want to avoid. They can squat down to pick something up off the floor. And then 2 weeks after surgery, I usually let them start lifting about 10 pounds again and adding a few pounds each week. I usually say start with a gallon of milk and work up from there. It's all patient dependent and they're recovery dependent. Everybody's different, but I would say those are some general precautions we do immediately post-op. And then, like I said, he'll go back to golfing again if that's what he wants to do, which obviously involves quite a bit of twisting. The reason that we do these surgeries is so that our patients can return to their normal daily life and return to their normal functions. We really want to avoid putting too many restrictions on. Oh, hi, that's okay. Sorry, that's okay.
I needed that.
Oh, that's fine. Yeah, we want them to get back to their normal life. So we don't want to tell them, you can't ever do that again. So we want them to return to their normal activities after surgery. Thank you.
Yeah, definitely. That seems to be the big picture with any surgery, is that the best outcome so that they can go back to life.
Yeah, absolutely. A lot of patients think we're going to restrict them from doing lots of things, but that's not why we do what we do. My surgeon always jokes around, I don't care about your pain, I care about your function. And obviously that's not true. We don't want our patients to be in pain, but the main concern is their function. So that's why we do these surgeries.
Sure.
Yeah, that's amazing. So that would be all the questions that we received for the case study. So
Okay.
we're going to be ready to move on. Perfect.
All right, final thoughts, guys. Being a PA is literally the best job ever. I'm so glad that this is the path that I chose, that this is how life worked out for me. I couldn't imagine doing anything else. I truly love what I do. And I do really think that surgery is a great place for a PA. I know I was super scared of it going into my rotations, but I think that surgery is a really special place for a PA. You work so closely with your surgeon, at least I do. The collaborative relationship is really unique in the sense that we are genuinely a team. We are a unit that functions together. And it works out really well for us. Don't get mad at me for this one, but know your why, know why you want to be a PA, and don't become a PA for a better work-life balance. That's okay. It's okay if that's in there, but that shouldn't be your main reason for wanting to be a PA. I work pretty hard. Like I said, there's 60, 70-hour weeks. I take call. I'm here at all hours of the day and night. It's a lot. It's emotionally and physically exhausting work. And I do think I have a good work-life balance, but I don't think it's any better than a doctor's. So know your why, make sure you really know. Don't be like me. Don't jump into something without fully evaluating your options, or be like me. That's okay. That might be your journey too. That was mine, but that's something that's important to me. And I don't love hearing people say, I want to be a PA because it's better work-life balance. I don't think that's entirely true. Know that PA school is hard, but it is totally worth it. You will make it through. It is doable. People have done it before, and you'll do it too. But don't forget to take time for yourself and to have fun along the way. And that's really all I have to say.
Awesome. Thank you so much for those tips. That's definitely priceless from somebody who's going through it right there. Like, you know, it means a lot that you're able to share that kind of stuff with us. But yeah, we have amassed quite a few questions through the course of this, if you're ready for it.
Yeah.
All right, let's do it. Okay, so starting off, Diane is asking, when would be the right time to apply to PA school if someone has little PCE hours? And I'm assuming she means like what part of the application cycle? Like, is it okay to wait a few months, or should you still apply in the beginning?
You know, there are some schools that actually don't require PCE hours. Western was one of them. I don't think they required any. They were bigger on volunteering, actually. So some of my classmates didn't even have PCE hours. But if you're looking at a school specifically that requires patient care hours, I think you would, I mean, I'm not an admissions expert or anything, but I think it would be important to at least have enough, or know that you would have enough by the time that you would interview, to make yourself a good candidate, a competitive candidate. So I don't know what those hours are these days. And like I said, the school that I ended up going to didn't actually require any, even though I had whatever 8 months of full-time plus my respite, my part-time respite job. That's how many hours I had. And I applied after both of those jobs. But yeah, I'm sorry, I don't have a super awesome answer for that because I'm not up on any of the admissions criteria right now.
No,
No,
I do
for sure.
think that was a great answer. Thank you. So the next question is, how did you address your previous application to medical school in PA applications and interviews? How did you make it clear that it wasn't a backup plan, but a change of heart?
Yeah, you just have to be open and honest about stuff like that. I did call it a change of heart, and I didn't try to hide it or anything. I had MCAT scores instead of anything else. So I just said that I really did my soul searching, and it took that part of my life and that part of my journey to get to where I was. And I think just being genuine about things like that is important. And like I said, you really have to know your why you want to be a PA. And if you're able to adequately articulate that and show that you understand what a PA's role is and how you are going to fill that and why you chose that instead of medical school, if that's what you applied to in the past, that's what's important. I can't remember if it really came up during my interview too much. I think I probably had to talk about it in my application. But I just said kind of what I told you guys. I did my soul searching. I realized why I wanted to be a doctor, and that it wasn't that I wanted to be a doctor, it's that I wanted to do this, 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 and this, and that I could do that without being a doctor, and that being a PA was actually a better fit for me personality wise.
That's incredible. Yeah, thank you for being so transparent. It seems like the school appreciated that as well. We can tell you really like what you do. Like the whole time you're giving this presentation, you're literally smiling the entire time. You
I love
know,
it so
awesome.
much, guys.
That's incredible. So Anne is following up on the previous question. So I know you said it's good to be genuine and disclose this kind of your reasons for switching, but if for whatever reason they didn't want to disclose that they had also applied to medical school, is that something that PA schools will be able to see, or is it something that would have to be disclosed to them in order for them to see it?
It's a different application process, and if you don't share your MCAT, well, I mean, even you could share your MCAT scores and they wouldn't know that you necessarily applied to medical school. So I don't think you would necessarily have to talk about it. I guess if it were to come up at any point, though, there might be concern if you, I don't want to say hid it, but didn't disclose it, that being a PA is a backup plan, even if it's absolutely not for you. not putting it out there might seem that way. So you got to kind of weigh that with if you want to talk about it or not. I think there are ways to talk about it in an essay or an application that don't ramble on as much as I have in speaking it. You can probably summarize it in a sentence or two. But I mean, I would understand why you wouldn't want to disclose it, but I would be concerned that, you know, they would think maybe your heart isn't in PA. I don't know. Like I said, I was only involved in one round of interviews, so I don't really have a whole lot of experience with like the application process and what goes on behind the scenes in choosing PA candidates. So this is just what like my own personal thoughts on it.
Yeah, definitely. Thank you for sharing your own personal experience. So, oh yeah, go ahead.
So Sophia's asking, how do you think your experience at Western with different medical professions helped you with the large private practice you're at now?
Yeah, that's a good question. I honestly think it was called interpersonal relations or something. I don't remember exactly what the class was called that we went and met with the other providers, but I actually think it was more beneficial for them to see what a PA actually does, because a lot of them were like, tell me about being a PA, tell me what you do as a PA. It was pretty obvious that a lot of them didn't have experience working with PAs in the past. But I do think that it helped me to have a better collaborative approach, which, like I mentioned, was important for me when I decided to become a PA. And this office that I work at is so extremely collaborative. Even just today, I walked down to the neurology end of the clinic and asked one of the neurologists if they see cerebral palsy patients. And then I walked to the other end of the clinic and talked to the pain management doctor about, would you do an epidural steroid injection for this patient? So I think it made me more confident in approaching other providers and seeing myself as part of the team with them and how we all work together for our patients.
Yeah, that's really cool. Just being around that big wealth of knowledge all the time. I'm sure you learned so much.
Yeah, our office is really neat. It's a big office. Like I said, there's a ton of providers, and there are some days when we're all here at the same time. So there's, you know, a lot of rooms, and there's one main hallway where most of the providers stand to do their charting. So if you need to just walk down and talk to somebody, they're there, which can be kind of inconvenient when you're trying to get your charting done, but also kind of nice. It's so fun to hear the two neurosurgeons like talk with each other and plan cases, and it's neat to see the neurologist come over or go talk to the neurologists about some crazy stuff that you've never seen before. So I really enjoy this office. It's been a great place to work.
Yeah, that is so cool. That's really cool. Let's see. So Abby's asking, how did you find your interviews, and in particular for the subspecialty programs?
All of my job interviews I found on places like Indeed and Google Jobs, and the other one I used was the Colorado Physician Assistant Association website. Yeah, I just, like I said, I sent out hundreds of applications. Most of them I've never heard back from. I actually got ghosted by the cardiothoracic one I interviewed with. They just stopped talking to me. The orthospine one I interviewed with, they made me keep coming back to shadow like multiple times over months. And I just got a really weird vibe from them. I actually did get an offer from them, but it wasn't a good offer and I didn't feel respected. So I decided not to take it, which was kind of, you know, risky after not having a job for 6 months or so, but go with your gut. And if it doesn't feel right, it's probably not. And I know that wasn't the question, but I went off on a little bit of a tangent.
No, yeah, we think that's still amazing that you shared that information. That's a huge deal too, feeling respected and, you know, trusting your gut and knowing if that's right for you or not.
Yeah. And at the end of the day, those guys missed out. They don't know.
Sure.
They don't know they missed out. So Anna's asking, can you talk about the process of changing state certification? And are you still certified for California in addition to Colorado?
So I actually, I don't think I applied for my state license in California because I knew I wasn't going to stay there. We had pretty much made up our mind before I graduated that we were going to be moving to Colorado. So I actually started the application process for Colorado licensing while I was still in California. So I only have one state license. It's okay if you have more than one. You don't have to necessarily change it. You guys just reminded me that I have to pay for my certification before the end of the year. So thank you for that. I'm going to like write myself a note. Yeah, you can have multiple state license. You can work across, like you can travel between different states to practice. And I don't remember exactly how long the process took for me to get licensed because I didn't have a job. Like I wasn't on a time crunch because I didn't have a job yet, but I remember it wasn't quick and it was expensive.
Cool. That's an interesting thing that, you know, as a pre-PA student, I never even think about like the certification and all of this stuff. Like, that's just, you know, I'm trying to get in. That's so far in the future. I'll like, you know, but that's cool.
Some pretty down the line questions, but that's good. You're thinking ahead.
Definitely.
And so the next question is, since Colorado is pretty rural, do cases from all over the state get routed to your hospital? And could you explain what a trauma level 1 hospital is?
Yeah. So we do see cases. So I'm in Colorado Springs, which is considered southern Colorado. And when we are on call, we do get cases from all over southern and eastern and western Colorado. And sometimes we're sitting waiting on a transfer for hours at a time because that's just how long it takes them to get here. And we also do see patients that drive 3 or 4 hours to come to a visit with us. We've actually had patients drive from Kansas for a visit with us because they live in western Kansas and this is the closest place for them to see a neurosurgeon. So yes, we do have patients come from all over. And when we are on call for a lot of southern Colorado. There is another hospital system down here, the UC Health Hospital System. So they have their own on-call neurosurgeons, but we end up seeing quite a bit when we're on call. Level 1 trauma center just means that we get the high acuity stuff. So we're able to take care of pretty sick patients and pretty beat up patients.
Wow, how interesting. We live in a metroplex, so there's like a million hospitals around, so can't imagine. That's crazy.
Yeah, it's kind of crazy to think about because Colorado Springs, I don't know exactly how many people live here. I actually live 45 minutes away, so I'm not super familiar with this city yet, but I think there's like 500,000 people. So it's a pretty decent sized city, but the rest of the area surrounding it is so rural that we do get a lot of patients from far away.
Yeah, going into town to get their medical work done, I guess. So this one's pretty straightforward. Blanca's asking, do you ever get nauseated during surgeries? And if so, how do you cope with it?
So that was something I was super worried about, obviously, like going into my rotations. I haven't gotten nauseated because of surgery. However, I recently started getting migraines during surgery, which is not awesome. It's happened a handful of times. And I get nauseated when I get a migraine. Usually I just push through it, but they've been happening during the longer surgeries. I honestly think it's because I just got my surgical glasses. They're pretty heavy. They're magnified so I can see what we're doing a little bit better, but they weigh a few pounds. And when I take them off, I feel better. So one time when it happened, I was able to dip out for just a minute during the part where we do the imaging for neuronavigation. I just left, I scrubbed out, I went to the locker room and took some ibuprofen and then went back in and kept going. So yeah, hopefully these migraines go away though. That's not fun.
I'm so sorry to hear that. I get a lot of migraines too, so I can't imagine how it feels during a surgery, especially if it's going to be several hours long. That's crazy.
Yeah. I finally went to my PCP and got some migraine medication, so hopefully that will help. I haven't had any recently, but I'm prepared now.
Yeah, seriously, I hope that helps.
Hope it gets better.
Yeah, my surgeon suffers from migraines as well, so he understands, but we just push through together.
Oh my God.
And like I said, in my OR tips, read the room, because sometimes both of us just so quiet and feel awful, and both have a migraine. And if someone starts talking to us about how our weekend was or what we did for Thanksgiving or starts asking questions, we're gonna get mad. So
Yeah.
read the room.
Oh my God, it makes sense.
Oh, yeah.
I get a headache like once a year, and that day I'm just like, cancel everything. I'm done. I can't, you know. But this is a good question. Camille is saying, I love how you integrated faith into this. How did you keep the faith through the struggles in school, like getting C's or not getting employed right away? Good question.
Yeah. I actually see all of that as part of my journey to get where I am today. I'm going to get a little deep into my faith right now, so if you aren't into that, just tune out for a minute. But my favorite Bible verse is Jeremiah 29:11, which says, "For I know well the plans I have in mind for you, says the Lord, plans for a future full of hope." And that was something that I held on to so close to my heart during all of this, especially when I realized that medical school wasn't the right route for me. I knew that God had a different plan in mind, and I just trusted that it was the right plan, and it was. And like I said, I ended up here. I truly believe that that year off was meant for me to end up exactly in this position with a surgeon who is an extremely Christian man as well. He and I have pretty deep faith conversations sometimes, and I think that he needed me as much as I needed him. And so God knew that, and that's how I ended up here. So I look back on that year of unemployment as just the trial I had to go to get to where I am today.
Incredible. That's
Thank you for
awesome to
sharing,
hear.
yeah.
And a lot of people in the chat are saying that
That
they
they
love
love
that
the verse.
verse, and it's great to have that support behind you, especially when in moments like that.
I prayed that verse so many times, you guys, for years and years and years. And at my graduation ceremony, that was the opening prayer. So
Oh man,
wow,
that's
that's amazing.
I cried. I was like, this is amazing.
Oh.
seriously. There's like poetic justice right there. That's awesome. So let's see. This is a good question. A lot of people were interested. Sage is asking. Oh, I'm sorry. We'll get back to that one, but what was that? Oh, Katie's asking, did you get married after PA school? And do you have thoughts on maintaining a relationship / marriage through PA school? And was that hard? And what worked?
Yeah, those are really good questions. I got married after PA school, but I was dating my husband that whole time we lived together. So I know that's not exactly following the faith, but that's just how it worked out for us. We got married in June of last year. So in the middle of my unemployment, which was pretty rough, I was feeling pretty depressed at that time. And it was hard to think about being around all of our family and not having a job and just kind of having to explain that. But luckily nobody, pressured me, which is great. I have an awesome family. We got engaged during my rotations while I was out on rotations, and then didn't start planning until after graduation. And as far as maintaining relationships during PA school, I'm going to talk a little bit about spousal or, intimate relationships like that, and then about friends as well, because I have thoughts on both. My husband put up with a lot from me. My boyfriend at the time put up with a lot from me during school. But I think laying out expectations was really beneficial. So I would say, I have a really busy week this week. I have like 4 exams. I'm going to have to lock myself in the spare room and just study. And he would know that, and he would leave me alone. On the weekends, he would go for hikes by himself, or he would go hang out with friends if I couldn't do stuff. So just having him know what to kind of expect, even though that could change last minute, was important. And being with someone who did understand that and who knew how much I wanted to be a PA, he really pushed me to be a PA. I actually wouldn't have ended up at Western if it wasn't for him, but that's a whole other story that we won't talk about right now. So yeah, laying out expectations and setting your boundaries too, because you are going to need them. There are going to be days when you have to say no to things. And that's what takes me into talking about friendships as well. We had some really great friends that we made in LA. I told them no more times than I would care to admit. They would want to go out for dinner, and they lived like 45 minutes or an hour away without traffic. And in LA, traffic makes a big difference. So, I would have to tell them no. And they didn't like it, but they understood and they were supportive and they just wanted me to be able to be a PA. And those are the kind of people that you need to surround yourself with in school. People who will understand and not get mad when you have to say no to things. But also, like I said, you need to have fun. So you can't say no to literally everything, but you do have to know that for 2 years or however long your program is, you're going to be a little bit selfish. And the people around you are going to have to understand that too.
Yeah, absolutely. It's important to make that balance. We'll make sure that your boyfriend doesn't see this part. We don't want to give him a big head, right?
Yeah. No,
Or a husband, sorry.
he knows.
He knows. Okay.
So let's see. The next question is, could you explain the job you had before PA school? What did you do at the nursing home, and did you need to get certified or anything like that?
Yeah, I was a certified nursing assistant, or a CNA. I think it's like a 6-week class that you take to become certified. It's through a technical college. And then you just have to take a test with a practical hands-on portion and a written portion. It's pretty simple, basic knowledge that you'll need to pass. And tasks that I would do would be, I worked the morning shift, so I would have probably 8 patients on a normal day, or 8 residents, we called them. And I would wake them up, get them dressed, get them cleaned up, help them brush their teeth, get them to breakfast. If they needed help eating or being fed, I would do that. Then we'd take them back to their room. They would I'd help them to the bathroom if they needed help. I'd help them take a shower. Then we'd do it all again for lunch. So it's basically, in a nursing home, personal cares. There are CNAs in the hospital as well, and they do a lot of the same things, but just like not with a resident, just with an inpatient. So it was, like I said, a lot of physical labor, getting patients who can't really walk or move in and out of bed or on and off the toilet. It was a lot of work, and I had to have all 8 of my ladies. I would start my shift at 6:30, and they'd all have to be cleaned up and dressed and ready for breakfast by 7:30. Like, it was a lot. But like I said, it was pretty rewarding. I don't know that I could have done it for more than 8 months, but I learned a lot. I got really comfortable touching people, which sounds like a really weird thing to say, but I did notice during school, like I said, Western doesn't require patient care hours. At least it didn't when I applied. So a lot of my fellow classmates didn't have experience actually hands-on with patients. And you could kind of tell that during our physical exam sessions, that they weren't as comfortable touching someone, listening with a stethoscope or something, or as I had wiped butts and cleaned ladies in the shower, and I was not afraid to touch anybody. So in that way, I think it was helpful. And that's kind of what being a CNA is.
You're incredible. Like that sounds so intense. I can imagine. How are we doing on time? I know you're still at work right now, working out of your office, so I don't want to take up your whole.
Yeah, let's do like 5 more minutes. Is that
okay?
Okay,
so I think this is a pretty good question. Oh, sorry about the phone. I think this is a pretty good question to end on. Just asking about your opinion on the future of PA. So the trends that you see the job will see in the future. If you could discuss things like salary, saturation, or where their role in medicine will shift to.
Okay. I can do that. I might not have the same views as everyone else, because I personally really think that PAs are meant to be in a collaborative role with physicians. So optimum team practice, I think, is important. I don't think that we should be out there practicing without a supervising physician. Obviously, it's cool if PAs are like in an urgent care or in a family practice setting where they don't have a physician there, but I do think that that relationship is still important and should be present. I think that we do need that. We only go to school for 2 years. So I don't know everything. I don't even know half of everything there is to know that my surgeon went to 9 years of residency for and has been practicing for 9 years. I've did 2 years of school, didn't see a single neurosurgery patient during school, and have been doing this for a year. So I definitely think that that team aspect is important. I also personally think physician assistant is not a bad term for us, and that we can just call ourselves PAs, but I won't start up that argument right now either. As far as salary goes, I don't really know how much detail to talk about this in, but the AAPA puts out a salary report every year, and I would say, at least from what I've seen, in my current position, it's on par with the national average. I did just get a raise after being here for a year, which was really, really great. And one of the reasons that I didn't take the position before is because the salary was so much lower than the national average that, like I said, I didn't feel respected. It wasn't even worth negotiating with. It was so low. So if you are out there looking for a job right now, just know your worth. Use the AAPA report to know your worth, and don't settle for anything less, because you're going to be working hard. And then as far as oversaturation, I mean, obviously, you guys, it took me a year to find a job. So there are a lot of PAs out there. There are a lot of experienced PAs out there. I think that's one of the reasons why it was so hard, is because I was a new grad, I didn't have experience. But also, there's a lot of aging population. Medical practices are growing. So I think there is a place for everybody. It just might take a while to find it.
Okay,
Thank you so
awesome.
much for
I
that.
think that's a great point to end on. Thank you so much for doing this. That was an incredible presentation. It's funny because in the beginning you were talking about how you thought some other PAs were like, really sharp and on top of everything, but like we hear you go through this and you're dropping words like stereotactic craniotomy for resection, just like like it's nothing. So yeah, that was incredible. I know you might go back and look at the chat if you want to on YouTube, just so that you can see, all of the comments you have. But just to give you an idea, we had about 180 viewers all the way through.
Wow.
Yeah. And so much support. Like everybody really loved your answers to the question. Millions of thank yous. Like, you're so awesome. Good point. Just like the whole way through, everybody really loved you. So sincerely, thank you for doing this. We really appreciate it.
Yeah, no problem. I'm so glad you guys all stuck through my technical difficulties too. I don't know what was going on, but I'm glad to hear that, we were able to help so many people out today.
Yeah,
For sure.
definitely. I think a lot of people learned quite a bit, ourselves included. But yeah, congratulations on everything. We know this is like kind of a long time coming for you, but it seems like everything's falling into place. So definitely congratulations. It seems like you deserve it.
Thanks guys.
Yeah, absolutely. Do you have any closing statement or anything you want to add on?
I was really glad that I got to do this. I've been wanting to have students shadow for a while, but I guess I've always been kind of nervous about not knowing enough, and being a new PA and not sure how my surgeon would take it if I had someone here. So COVID sucks, but I'm glad that it gave us this opportunity to do it like this, and that I could help, that so many people could spend an evening shadowing with me instead of just, helping one or two people. So
yeah, absolutely. And I don't think anybody that shadows you will ever think that you're undergrad. You seem to like, you're
I'm
amazing.
sure they would love you as well. And you were able to answer everything so perfectly. So
yeah, those were some tricky questions and you were on top of it. So
thanks, guys.
Yeah, absolutely. Well, thank you so much again. Sorry we made you stay at work, but
I'm used to it. Like I said, I'm here all the time.
Awesome. Well, enjoy the rest of your night. We hope you have a good vacation.
Yes.
Yeah. Thank you.
All right, take care, guys.
All right, take care. Good night.
Bye.
Bye.
All right, everybody. Really good presentation.
Thank you.
Yeah, thanks so much for joining us. We're about to link the quiz right now. We also posted a link to her Instagram if you guys want to follow. She has a really cool Instagram. She shares a lot of neat things.
I pinned it at the top, so it should be there in blue, but I will probably replace it with the quiz link in just a second.
Yep. So quiz is incoming right now. Same deal. You just get 4 out of the 5 questions correct, and we will email you a certificate. It usually takes us about 2 to 3 days to send that out, but if not, give us a week and then shoot us an email if you haven't received it. But you should see it pretty shortly there. But yes, guys, we have many more sessions coming in December, so stay tuned. We will be able to provide you guys a ton of shadowing hours, lots of really good experience. We try and do different specialties every time, so you'll see a lot of different things. We have a psych PA coming up, which was one of our more requested ones and kind of an interesting thing. So yeah, guys, stay tuned. If you have any questions for us or anything like that, we'll be hanging out in the chat for a bit. But yeah, everybody, thank you so much. Good to see you again. Take care.
Oh, and also a long time ago, we put out a poll for whether or not we should create like another group just so we can be more interactive and you guys can be more engaging with each other. And then Facebook did win, but we did make both. I can also, the link to join our Facebook group and the group me is in our bio on Instagram. So if you want to join either of those, that is in the link in our bio. And I did just send out the link for the quiz. There is an hour for the quiz, so it'll close at 8:30 Central.
Yeah.
So that's it.
All right, guys. Thank you so much. We'll be right here if you want to ask us anything. Thanks again. Good night.
Have a good night.